My name is Tom Bornemann. I'm the director of the mental health program here at the Carter Center, and it's my pleasure and privilege to open up this meeting today. I want to welcome all of you to the center. I see so many of our regulars, and it's great to see you and renew friendships again, and to see a number of new people so we can add to the number of people that we are involved with. Unfortunately, we're on a very tight schedule. So please feel free to bring your refreshments back into the room so you can bring them into the room. So we can start on time when we go from session to session. Restrooms are on the floors up and down, easily marked right outside that door there. This year we're encouraging people who are not taking the shuttle to the airport at the end of the symposium use Uber to get where you're going. There's also a list of taxis. There are some challenges every once in a while getting to the Atlanta airport, so we want to make sure we take care of that. We encourage you to participate in the symposium on social media, and you have our social media address there, and we've got our professional staff here that could help you with that on some of the social media, so we're excited about that. I would like to thank everybody attending this year's symposium. This is the last one in its current form. And let me emphasize that, in its current form. We've done some real examination of our 32 years of resounding work, wonderful work, work that's lasted, and work that people use and appreciate, and we're thankful for that. But beyond that, our field is changing. And we had to come to grips with the fact that the field is in fact changing, and hopefully our response is to that. The center will continue to work with the mental health and substance use fields to identify emerging policy issues, and when we see one, we're going to work it, and work it hard, but we're going to work it a little bit differently. We'll move to a group of smaller meetings, more targeted meetings, seeking results that are replicable and can be dispensed throughout our community. So many of you will be hearing from us still. It won't be in this grand amount, but in smaller chunks. And I wanted to let you know that up front. And if you have any questions about it and want to talk to me or Lee or any of our staff about it, we'll be glad to talk to you about it. We think it's the right thing to do at this time in the evolution of our programs. And we're very excited about the opportunities it's going to present to us in terms of moving to being able to stay with the topic for a bit and get some depth on it. And that's clearly what we're looking for. With that out of the way, I get the distinct pleasure of introducing my boss, Mrs. Rosalynn Carter. Mrs. Carter remains an enduring member of our mental health community and our leader here at the Carter Center. Mrs. Carter.
Thank you. Well, I want to welcome all of you to this symposium and to the Carter Center. And we have a great day and a half. Well, we have a half a day and then a day in our symposium. And we have a really good program. I'm excited about who is speaking and what we're going to be talking about this afternoon. As Tom said, this is our 32nd year of having symposium. And during that 32 years, our symposium has focused on improving mental health and substance use care in our country by promoting access to appropriate, high quality, and affordable behavioral health care services. And at the same time, we've really worked hard to reduce the stigma and social isolation that is associated with these conditions. In 2008, we launched the Carter Center's Primary Care Initiative, and since then we focused on promoting the acceptance and integration of behavioral health and prevention, mainly into the primary care sector. And it's now been 8 years since we started doing that. And while there are still challenges to its full adoption, we're excited to see that integrated care is increasingly becoming the expected standard of care, and that is so exciting to me, because we work so hard on that to get people to realize how much primary care health and behavioral health goes together. However, and I have to read this and this is going to explain to you what Tom was talking about, what we're doing. Over the last few years, as we continue to make progress, we realized that the need for better integration reached far beyond our focus on primary care. That is why we've supported efforts to increase the emphasis on more effective integration of behavioral health and prevention into such areas as the education of health professionals, the faith-based community, and most recently, the workplace. This year, we are broadening our integration work even further by beginning to focus on a most timely issue: the central role of behavioral health and wellness in managing the overall health of populations. The truth is that in order to truly impact population health, we must not limit our focus to treating illnesses. We must also work to build a culture of health and wellness, including, of course, and most importantly, behavioral health and wellness within communities and organizations. This expanded focus is reflected in this year's symposium speakers, in you, our attendees, and what are sure to be engaging discussions. With us today, we have individuals from a number of different sectors, including the medical director of IBM Watson, a sheriff, and an OBGYN forensic pathologist, a reverend, and an educator. Our goal is to bring together many different perspectives, and this says to fuel our conversations and guide our work in addressing the relationship between behavioral health and population health. I look forward to these conversations because I have a lot to learn about these issues and how we can go about bringing everybody together to be working on health and wellness. Well, to help set the stage, we have invited Dr. Paul Summergrad to deliver today's keynote address. I'm so pleased, Paul, that you could be here with us. If you look in your packet that you got today, his full biography is there. But I wanted to point out that Paul is psychiatrist in chief for Tufts Medical Center. He also is Dr. Francis S. Arkin, Professor of Medicine and Chairman of Psychiatry at Tufts University School of Medicine. And I also just had a note saying that he was the president of the American Psychiatric Association in 2015. Welcome, Paul. Let's give him a good welcome.
Thank you so much.
First, I want to thank Mrs. Carter both for that warm introduction and for the kind invitation to be able to speak with you today. I particularly want to thank Mrs. Carter for her tireless and groundbreaking advocacy on mental health and so many other issues. Watching her clarity and moral force last spring at a meeting of the White House Parity Task Force that occurred at the American Psychiatric Association meeting is a reminder of what's possible to accomplish in this world if we stay focused on the needs of others and particularly act with morality and dignity. So I just want to thank her very much for the invitation. The issues of thinking about integrating care or thinking about what's now termed behavioral health in all of medical care is a large one, and it's increasingly been in our discussions in public policy and obviously a meeting like this. It hasn't always been so. In 1934, 96% of all the psychiatric beds in the United States were in state or federal hospitals, and the others were in a few private psychiatric hospitals, and almost none were in general hospitals. The few psychiatrists in the United States didn't work in general hospital settings. They worked in asylums and state hospitals. And there was little attention, so little attention to the psychological or social determinants of health in medical school curriculums that in the leading medical journals of the 1930s, medical educators wrote about how we had lost the relationship with patients and lost the focus on the human elements of care. So how did we get from the early 1930s to now? And I really want to try to tell a story here, and it's a story that I think is important not just for us here, but is really important as well globally. To move to a situation where the integration of behavioral health, of general medical psychiatric care is a topic for a meeting like this. In part, the story begins with visionary leadership, as I guess it almost always does. And in this case, it was a visionary leadership of an extremely important American healthcare foundation, or foundation in general, the Rockefeller Foundation. Now, let's see if I can get these slides to work here. Next, is there a way to... Besides my disclosures, let's see. Okay. One more. There we go. Let's see if it stays there. So Alan Gregg was the medical director of the Rockefeller Foundation in the early 1930s. And Gregg was a public health physician. He was trained in infectious diseases. And he understood, as a few other people did, he had worked in Brazil and other places dealing with a whole variety of very epidemic infectious diseases. But he understood that as infectious diseases came under control, as they would in the United States throughout the 1930s and 40s and 50s, the burden of what we call non-communicable diseases would become more important as a total burden of illness and of health care. And the shift to these chronic disorders would be the largest shift would really be to psychiatric disorders, because it was really the largest unmet burden. 25% of all the hospital beds in the United States in 1934 were in psychiatric hospitals, 25%. And there was terribly little research on psychiatric illness in those settings. And the kind of work that had been done in academic medical centers in the 1920s and 30s throughout the United States was not really being applied to psychiatry. So the question was really, could something be done to improve the quality of research, intervene earlier in the course of illness, train physicians in psychiatry and behavioral health, and do more to intercept the burden of illness, both in terms of psychiatric and substance use illness, but also comorbid illness. So the Rockefeller Foundation did something extraordinary. They basically invested the equivalent of about what's now probably $150 or $175 million in current dollar terms that went to 8 institutions in the United States. And they did this throughout the 1930s. Mass General, which was the major teaching hospital of Harvard Medical School, University of Chicago, Yale, and others. And they also invested in neurology. I'm not sure that there we go. Let me go back one. Is there a way to control the slides from up top? In any event, now let's go back one more. Thank you. So that basically shows the Mass General Hospital circa 1930, when there were no psychiatric services at the hospital, and I trained there, and Gregg's influence was felt throughout that institution because it created what is now one of the preeminent psychiatric services in the world. And they also invested in key research units in neurology throughout both the United States and in Europe. And this recognition that psychiatric illness is highly prevalent, that its burden increases as infectious diseases come under control, and that research, clinical care, and prevention in the setting of general health care, all of those understandings, I think, are really central to our thinking about this issue of integrated care and rethinking behavioral health. So what do we mean when we say that behavioral health is central to all of healthcare. And what is it that we know about these conditions that I believe that this is demonstrably true? I think it's also true that no high-performing healthcare system in the United States or elsewhere is going to be truly successful unless it's expert in evaluating and managing behavior. And I want to talk about that in a broad sense. I don't mean just in the management of psychiatric illness, but behavior more broadly. So we know that many medical disorders can worsen the course of psychiatric care, many psychiatric illnesses can worsen the course of general medical care, and that many medical disorders can directly produce psychiatric illness. I remember when I was a medical resident at what was then called the Boston City Hospital, the most common admitting diagnosis to the hospital, this is on general medical services when I did my internal medicine residency, was altered mental status. We know that 10% of people in general hospitals have delirium at any given time, and that's associated with agitation, confusion, visual hallucinations, auditory hallucinations, and a whole range of other neuropsychiatric symptoms. We know that medical illnesses and psychiatric illnesses are highly comorbid. Next slide. Next slide. And this is just a brief cartoon showing the overlap between medical and psychiatric illnesses. And for the vast majority of people who have psychiatric illness, most of them have chronic medical disorders. And likewise, for many people who have chronic medical disorders, psychiatric illnesses of various kinds are highly prevalent and highly common. We also know that in too many cases, medical illnesses are ignored in patients who have psychiatric illness, either because the systems are not in place to take care of them, or people discount symptoms that people actually present to them. We also know from numerous studies that many people who have psychiatric illnesses have increased rates of medical illness and that they have early mortality, and that these illnesses and early deaths are not simply due to the impact of psychiatric medications or even suicide, but a great many of them are due to general medical deaths that are preventable. And this is not something that's new to our era. It's not simply that people aren't able to get care. It's been true even in eras when high technology care was not available. And there's studies going back to the 1930s that show very, very similar findings in this country. So we know that it's very difficult in many psychiatric care settings, likewise, to access medical care, even though people have very, very high burdens of smoking and a variety of other illnesses that go along with that, hypertension, diabetes. So we know that getting preventive care, secondary treatment, routine screening is not really occurring in the way it needs to in general psychiatric settings. And it's not occurring as well as it should throughout the specialty healthcare sector. So when we think about this, the reality is that it's not that medical care and psychiatric care happen in different places, but they don't happen well. For example, the medical care doesn't happen well in the specialty psychiatric care sector. The same thing is true in the general medical sector. We know from work of Daryl Regier and Mark Olfson. Next slide, please. This is a cartoon from the 1978 paper, classic paper from Daryl Regier, and it answers the question, who cares for patients? And that pie chart, this is before the era of PowerPoint, they made this, that pie chart shows essentially that the majority, that big section in the bottom, is the general medical sector. That's the place where the most common place where care is being delivered for patients with psychiatric illness for their psychiatric symptoms. And Mark Olfson's work in 2013 showed the very, very same thing from the National Ambulatory Care Database. So this leads to a recognition that psychiatric care is actually occurring in the general medical sector, and indeed it's an important part of the general medical sector. But like in the psychiatric specialty sector, it's not occurring very well. It's not being done as well as it should. So this leads, I think, to the first of the ways that we really need to change the way in which we think. And that is, the patients who come to see us are already integrated. They come with all of their problems, all of their illnesses, all of their social determinants. It's we who are fragmented. Our system of care is fragmented, and we don't we don't pay the attention that we need to the range of problems and services that they require wherever they appear for care. We don't screen people as well as we should, and it doesn't mean we're not going to be doing heart surgery in a specialty mental health sector, and we're not going to be doing other things in the general medical sector that need to be done in the specialty sector. But we need to be tracking and paying attention to the full range of people's illnesses and life circumstances wherever they appear. And that's in part what we need to do in this integration agenda. We also need to make sure that we understand that behavioral health care sector includes the general medical sector, just as the general medical sector also includes being in the specialty behavioral health sector, and that we also need to understand that what we call mental disorders are mental disorders because of their symptoms. It's not always what it is that's causing them. Mental disorders are mental by their symptoms, but there are lots and lots of different kinds of things, from environmental circumstances to personal circumstances, that can cause them. And we need to be aware of that as we think about the integration agenda. We know that psychiatric and substance use illnesses are the most common illnesses of young people. Next slide. So this is a really important slide from the Journal of the American Medical Association in 2015. And the area, what this slide shows is on the x-axis is age, and on the y-axis is amount of burden of illness. And then the various colors represent different kinds of illnesses. So the dark blue are the kinds of things that kill you as you get to the end of your life. All the way at the right-hand side of the slide is age 85 and above. And those are the periods of time when people get heart disease, they get lung cancer, they get other forms of cancer, pneumonia, COPD, and those are the things that kill people or cause disability at the end of life. The green, for example, is injuries, falls, self-harm, road accidents, etc. The area that's circled, that kind of lighter blue that's in the circle, is between the ages of 15 and 45, and it's the dominant burden of illness between 15 and 45, and it's mental health and substance use illness. Mental health and substance use illnesses are the preeminent and the predominant illnesses of people between the ages of 15 and 45. If you ask most parents what they're worried about when their kids go off to college, and I've now got a, knock wood, a 24-year-old and a 25-year-old, they worry about them getting into accidents, they worry about substance use, they worry about them getting depressed. Yes, and remotely people worry about, as they should, terrible, rare illnesses befalling them, but the average 24-year-old doesn't have problems with heart attacks, or the average 20-year-old. What they have problems with is psychiatric and substance use illness, and any college president will tell you the same thing. So we also know that these illnesses, because they occur over a long period of time and they're chronic, have a long tail. They have a big impact on what happens as we get further on in the lifespan. Next slide, please. So this is from that same paper, and what this shows you is the major causes of death over the lifespan, and then the risk factors for them. And the dark blue, as I mentioned before, are all the things that tend to get you at the end of life: heart disease, stroke, chronic obstructive pulmonary disease, lung cancer, etc. And the stratification on the left are causes, the risk factors for illness. And of the top 7 risk factors for illness, they're dietary risks, lack of exercise, overweight, substance use, alcohol use, smoking. 5 out of the top 7 risks are behavioral risks. So as we rethink behavioral health, we need to think about not just behavior. These are not necessarily due to psychiatric illnesses, although they're more prevalent in people who have psychiatric and substance use illnesses. But they are burdens of illness that we have to figure out how to manage, because they're the things that are driving an enormous amount of our healthcare costs. So the impact of psychiatric illness on human suffering should be enough for us to provide care and support for people. It shouldn't simply be that the cost of medical care is what's driving our concern. But it's sometimes a really important factor, as all of us who have to deal with budgets know. We know that from many studies, including the report that I had the honor of leading when I was at the American Psychiatric Association, which we commissioned from Bornemann, that the increased medical surgical costs among patients who have psychiatric and substance use illness is about $250 billion a year. So I want to say that again. if you take individuals who have mental health and substance use disorders and you compare their total health care spending to individuals who don't have mental health and substance use illness, the amount that's spent on their care outside of their psychiatric and substance use care is $250 billion a year more than we spend on folks who don't have mental health and substance use illness. And that's not because folks are going to see their primary care doctors all the time, or they're going to see their psychiatrists or psychologists all the time. It's in emergency room care, it's in hospital facility care, it's in readmissions and admissions to the hospital. Next slide. Next slide, please. Thank you. So this is just, it shows the split between the amount of money that we spend through insurance on mental health and substance use services, which is about $92 billion a year through Medicare, Medicaid, and commercial insurance. And the increase in medical surgical care costs is about $250 billion a year, every year. That's about 10% of total U.S. healthcare spending. Next slide. This was found in a number of other studies, not just the work we did for Milliman. PricewaterhouseCoopers did a study both in the U.S. and Europe and found the same thing. The Nuffield Trust in the U.K. found the same thing, and again found the same pattern of people being admitted to the hospital, even for things where they ordinarily wouldn't have to be admitted to the hospital because they were so disconnected from the healthcare system. In Massachusetts, this is the Health Policy Commission in Massachusetts, looked at what is the increase in cost if you have a chronic medical and psychiatric illness. For Medicare beneficiaries, the cost went up 700%, and for commercially insured individuals, it was up 420%. Next slide. This is data, again, from Massachusetts, and you can find data like this from throughout the world, through the developed world, showing that individuals who get admitted to the hospital for medical surgical causes, not psychiatric care causes, medical surgical causes, if they have mental health and substance use disorder, their rate of admission is significantly higher if they have mental health and substance use disorders. Next slide, please. So as we think about this, two other important conclusions flow from this need for us to broaden our thinking about behavioral health and about mental health and substance use. First is, it's not fully known whether better psychiatric or behavioral health interventions will lower the cost of care or improve quality, although there's a lot of indications that it probably will in selected populations. There's just a large study from the Intermountain Health System. Anybody here from Intermountain Health System? Intermountain Health System just published a study in the Journal of the American Medical Association where they invested $11 million over 4 years in team-based care, and over that period of time, they improved the quality of the care, number one, and they actually lowered their healthcare costs by about $52 million, so 4 times the amount they invested. And at the center of what they did in that team-based care was mental health integration, and this was really key. They said this was actually central. They had primary care physicians who, in their primary care practices, became champions of the normalization of mental health care. What does that mean? It means that taking care of folks who have mental health and substance use disorders, as I showed you in the earlier slide, is a common thing in mental health in primary care practices. And it's time that we begin to treat this as something that's normal and not a mistake, and make sure that we find ways of doing it better. If 30% of pediatric practices, and they do, say that the things that they see are child psychiatric related conditions, including neurodevelopmental conditions, then they need to make sure that they have the expertise both in their physician staff and in their practice staff to provide the appropriate level of care and type of care for those individuals, because all those folks are not going someplace else to get their care. The care needs to be improved where folks actually are. So, second, I think, and more importantly, we need to rethink the role of behavioral care within the medical system. Put another way, the evaluation and management of behavior, in addition to providing integrated care, has to become, as I said earlier, an attribute of high-performing healthcare systems. Before I close, I want to just throw out a couple of other thoughts about all of this. First is I want to make sure that we spend a couple of moments thinking about a broader issue that relates to all of this, and I know one that has been important to the Carter Center and to the work that you all do here, which is global mental health. Next slide, please. So this is a slide from West Africa of someone who was being cared for with a mental illness in the middle of a community, central area in a community. Now, we don't do necessarily a lot better here, so it's not like we ought to be patting ourselves in the back. We know how many folks are in jail or incarcerated with mental health problems in this country. Next slide. So this is a slide showing the ages and cause of death in the United States. And again, it's stratified on the x-axis by age, and then the colors represent different causes of death. And the yellow, which you see is just a tiny bit, kind of in the bottom right, represents a kind of infectious disease-related deaths. Next slide. This shows you the same thing in the developing world. And you see the burden of the yellow is so much larger. Infant mortality, maternal child health issues, waterborne diseases, infectious diseases are all in that yellow area. Next slide. This shows you the burden of disease between the ages of 15 and 49 in the United States. And the dark blue, in the blue areas, most of those are mental health and substance use, major depressive disorder, anxiety disorder, schizophrenia, bipolar illness. The green is self-harm, many of which is related to suicide or road accidents that are associated with intoxication. And the burden of infectious diseases is that little orange area at the bottom. Everybody see that? Next slide. That's sub-Saharan Africa. That's the burden of disease, the same age range in sub-Saharan Africa. That's the burden. There's a very good reason why the Gates Foundation and everybody else is investing in dealing with infectious diseases in sub-Saharan Africa, because that's where the burden of disease is. But what happens, like Alan Gregg talked about, when infectious diseases come under control, even in developing countries? Next slide. This is India. You see how India has lowered the burden of infectious diseases. And instead, what you have is you have non-communicable diseases, including mental health, as among the major burdens of illness. Next slide, please. China. So you may like Mao, hate Mao, but Mao said they were going to get rid of mosquitoes and fleas, and they got rid of mosquitoes and fleas, and they've lowered their burden of infectious disease. And what you see replacing it is mental health and substance use. It's not a surprise that China has just passed a new mental health law, is investing more in mental health services, is putting in place new psychiatric hospitals and settings, because they recognize that this is an increasing burden of disease. Next slide. This shows you the largest burden of economic impact in non-communicable diseases. The blue is mental health. The green is cardiovascular disease. They're the greatest burden in terms of worldwide burden currently. And the next slide, please, shows you that this is going to increase. That aggregate line at the top shows you the acceleration of the economic burden of non-communicable diseases, especially mental health disorders, throughout the developing world. And we know that there are not enough individuals in the workforce, there's not enough physicians, let alone trained psychiatric physicians or other mental health individuals in those countries to provide the kind of care that is going to be needed as infectious diseases come under control. And they will come under control. So this is a planning really for the future. We need the kind of work that all of you are doing here, as well as work that's being done from other organizations. We need the pilots and the scalable interventions, because we're going to need community-based health workers and others to be able to make sure that we take care of people in these countries as mental health and substance use illnesses become a greater burden. Next slide, please. So, I want to just close with one other story. So I like stories. I'm a psychiatrist, so I like to get stories from people, and I like to learn about their story. So I want to come back to the story of the Rockefeller Foundation. So next slide, please. Oh, sorry, go back one. I'm sorry. So 1933, there was a meeting of the Board of Trustees of the Rockefeller Foundation. And Alan Gregg presented his plan on investing in psychiatry and neurology, but mainly on psychiatry. It was a plan that had been put in place by the dean of Harvard Medical School, who was consulting to the foundation in 1930 because they were trying to figure out how to reorganize their foundation. And there were several people who listened to that plan. One was a guy named Raymond Fosdick. He was the lead independent director of the Rockefeller Foundation. Second was someone named Max Mason, who was a major board member. He was the president of the Rockefeller Foundation, and he'd been president of the University of Chicago. And the third was John D. Rockefeller Jr., who was chairman of the Rockefeller Foundation. Now, what's not commonly known is that all of these individuals, both themselves and in their families, had suffered grievously with the impact of mental health disorders. First, Raymond Fosdick's wife had bipolar illness, and in 1932, when this was an untreatable disorder, in a very public event that became published in the New York Times, murdered her 2 children and murdered herself in the middle of a psychotic episode. Max Mason's wife died of the medical complications of mental illness. John D. Rockefeller Jr. had had what was described as a mental breakdown in his 1920s, and indeed his father suffered from recurrent episodes. John D. Rockefeller Sr. suffered from recurrent episodes of mood disorders. So this wasn't an abstract exercise for these men, and they were all men in this situation. This was something that was very personal. Now, with all the shame and stigma and opprobrium that falls on psychiatric illness, they could have run the other way. They could have invested in something else. They could have went and hid and not talked about this and pretended that this never happened to any of them. But they actually did something different. They moved towards the suffering, and they moved towards the pain that they had in their own lives. And they understood that it's only by investing and coming closer to the expertise that exists in the healthcare system in general, in research, in prevention, in integration of care, that they were going to make a difference in the care that was being provided to their loved ones and their families, so that other people didn't go through the suffering that they had gone through. And that investment actually panned out very, very well. I mean, that's an extraordinarily important investment. So I think it represents something that all of us need to think about as we think about this burden of integration of care. Additionally, I think there are 2 other things we need to think about. We need to be careful, not just that we think about behavior properly, but also that we think about mental illness properly. First, not everything that causes suffering in this world is mental illness. Not everything even that causes anguish in this world is mental illness. People can have social, economic, political, spiritual causes of suffering, and we need to be mindful of that. Secondly, as we think about managing behavior in healthcare systems, and it's really important that we learn how to do this, we also need to be really, really careful that we don't just focus on behavior in an operational sense. Ultimately, we need to focus in on the physician or clinician-patient relationship. It ought to be something that's a very special relationship. We ought to be listening carefully, engaging carefully, taking careful histories with individuals, listening to the circumstances of their lives, and approaching them with respect in that dialogue. So again, it's not just in supporting the expertise and the evaluation and management of behavior. That's really important. But it's foundational for us that we need to really make sure that we are approaching the doctor-patient or clinician-patient relationship with the kind of respect it deserves. These are serious things that happen when people get sick. And it's not too much to say that these ought to be sacred encounters and not offhand encounters. And finally, I think, like the Rockefeller Foundation, we need to approach the issues of the way in which we think about mental health and stigma. Last slide. Next slide. So Abraham Lincoln, as many of you know, suffered from recurrent depression. And he wrote a letter to Mary Speed, who was his partner Joshua Speed's sister, in 1841, as he was suffering from a severe depression after the death of his fiancée, Anne Rutledge. And he wrote, "A tendency to melancholy," which was the 19th century term for depression. "A tendency to melancholy, let it be observed, is a misfortune, not a fault." So we need to approach these things also as misfortune and not as blame. And like the Rockefeller Foundation, move towards the sources of suffering, not away from them. Thank you very much.